All right, good afternoon, everybody. This is Mary Erickson with Mount Pacific Quality Health, and we're here today to talk with Dr. Eric Arzubi about integrated behavioral telehealth models and to just have some conversation about how that can work in your organization. So I see there's already some chat activity going on. So thank you, Amber, for watching the chat and helping us with those questions. So it will be fairly informal today, so we just want to go ahead and jump in and get started. Just as an FYI, we are trying to keep up with all the regulations as fast as we can, as you all are as well. So today's information is going to be as up to date as possible. And please reach out if you have any additional questions or share any additional information that you might have that we don't. So today you are all muted. So if you would like to ask a question, please put your question in the chat box. Otherwise, if there's some conversation you would like to have, we'll need to elevate you to a different role, and so you just need to let us know that. This presentation is being recorded and will be sent out to all registered participants once it's completed. Please share your experience as you're able to with the group, and be kind. We are all learning together. This will be a quick session today for about a half an hour of your time. So hopefully we can move on through things. So we're going to have some conversation today with Dr. Eric Arzubi, who has been in telepsychiatry practice for about 6 years, and he's located in Billings, Montana. So Dr. Arzubi, if you want to say hello to the crowd.
I'd be happy to. Hello. Nice to be here with everyone. Just by way of background, I may know some of you, but for the others, I was the chair of psychiatry at the Billings Clinic until November, and as part of my work at the Billings Clinic, did telepsychiatry the entire time I was there since 2013. And we also, probably beginning in 2016, started using telepsychiatry much more extensively, especially into the emergency room, our psychiatric emergency observation unit, as well as our inpatient psychiatric unit. And so we've done telepsychiatry, and Montana in general has been a bit of a pioneer anyway. So sorry, I think I started to launch into my spiel. So I don't know, Mary, was that time, or I was just supposed to introduce myself? Sorry.
Yeah, go ahead. Oh, go for it. Go ahead and provide us with the overview, and then we have just some questions here on the screen to go through, but
Great.
Yeah, go for it.
Okay. So yes, please, by all means, throw out as many questions as you have. Again, I'm assuming there's a lot of difference. There's a lot of difference in terms of abilities and experience when it comes to telemental health, telepsychiatry, and integrated behavioral health in general. So I'm happy to field questions across the spectrum. It's also, if you have questions about screening tools, workflows, that sort of thing, I think it's important. So as you all know, psychiatry in particular can be a very good specialty with which to start being more, let's say, more assertive when it comes to telehealth. Obviously, the need to monitor or use technology for monitoring is a little bit decreased, since a lot of what we do is working off of verbal and nonverbal cues and conversation. And there's plenty of research to show that providing psychiatric services over video is as effective as in person. And especially after this pandemic, we're going to start seeing a lot more research being conducted, not only around telepsychiatry, but about telehealth in general. And that will give us, again, more evidence and more research to either continue pursuing telehealth in a more aggressive fashion, or helping us to understand what are the most effective ways to provide telehealth services. So when it comes to psychiatry, you have a whole continuum of care, right? So at the most, let's say at the most basic, you have access to behavioral health in some way through primary care. And in fact, The gateway, as we know, to a lot of behavioral health services is through primary care, because primary care gets more access to our patients, and recently, in recent years, there's been a lot more behavioral health screening happening. And so the better that primary care offices can perform screening services and provide more robust integration with mental health services, obviously the better that is for population health in general. So there are two ways to kind of think of this. You can either do direct care, which again is sort of face-to-face over video, or we can think about it as sort of indirect care, where the psychiatrist provides, or a psychiatric nurse practitioner provides, consultation to a primary care team. What I'd like to do, if it's all right, Mary, can I share my screen real quick?
Yes.
Is it possible? Okay, great. All righty.
Stop sharing mine. There you go.
Cool. Thank you. And so, do you see? Does everybody see? Mary, can you see the team structure here?
Yep.
Okay, wonderful.
Yep, we see team structure. Mm-hmm.
Beautiful. So, for those of you who are interested in integrated behavioral health, there are, in general, integrated behavioral health is really the umbrella term, right? So that's kind of the generic, broad term for providing some sort of behavioral health in a primary care setting. But there are differences in the way integrated behavioral health is structured. Just because somebody provides behavioral health services in a primary care setting does not mean it's the same as all the different sort of variations of that model. The best way to kind of describe this is, I would suggest that everyone takes a look at, for those of you who are trying to do integrated behavioral health, look at the information at the AIM Center at the University of Washington. The University of Washington has for decades been studying integrated behavioral health and a particular model called the collaborative care model. And the collaborative care model has dozens and dozens of randomized controlled trials that have shown that this form of collaborative care is better than treatment as usual when it comes to mental health in the community. And just as a quick, sort of brief overview, the workflow is as follows. You have obviously the patient at the center. You have the behavioral health care manager who is at the primary care clinic, and the medical provider, the primary care medical provider, who's also at the clinic. And you have the psychiatric consultant sort of off to the side here, who really provides regular contact and consultation to the behavioral health care manager at the primary care site. Occasionally, there's contact between the psychiatrist and the primary care provider, but again, that doesn't have to happen frequently because you have your embedded behavioral health care manager doing that for you. And also, there's in order to do this model successfully, there needs to be a patient registry that is managed by the behavioral health care manager and is used as really a conversation tool to discuss patient cases with a psychiatric consultant on a weekly basis. When following all these elements of the collaborative care model, you can bill and get reimbursed for this using the collaborative care codes that were implemented probably over the last 2 to 3 years. About 3 years ago, it was sort of a preliminary version of the codes, and now in the last 2 years, they've been rolled out much more widely. And different states have varying approaches to reimbursement, but my understanding is that the collaborative care codes in Montana, when used, have been reimbursed. And so again, if you have these critical elements for the collaborative care model, you can get reimbursed for integrated behavioral health. And again, by doing it using this model, you can be assured that you're following a model that has robust evidence to show that this works and actually improves depression scores and anxiety scores over time. And actually does so better than treatment as usual, which is referring somebody off to a community health center or community mental health center, because a lot of times those patients don't make it to that referral, or they have to wait a long time. So again, here you see the role of a psychiatric consultant using telehealth or using video technology. Really, in this case, is acting as a consultant, where on a regular basis they will see the behavioral health care manager in the primary care setting over video, and then look at the registry together by doing something like what we're doing right now, is sharing the screen. And the registry is really a dashboard for a panel of patients, probably up to 50 patients per behavioral health care manager, where the psychiatric consultant and the care manager can discuss cases and really rank them by acuity. So most likely you'd want to work and talk about the most acute cases first, so the highest risk, and then moderate risk, and then the low risk. You may not have to have so many conversations. And then the other thing is, if you are doing integrated behavioral health, especially in the collaborative care approach, which again is the most evidence-based and most robust model, there might be times where the psychiatric consultant will say to you, you know what, integrated behavioral health really is, it's probably out of the scope of integrated behavioral health because that patient is too ill. And there you can perhaps use that same psychiatric consultant to do a face-to-face visit with the patient and help with diagnosis, treatment planning, and really just to lay eyes and make sure that the primary care team is on the right track. And more often than not, the primary care teams are on the right track and doing a lot of great work. A lot of times the psychiatric consultant kind of steps in and says, yep, kind of validating what's going on and saying, you know, just keep doing what you're doing because you're on the right track, and you may just have to wait a little longer, or you may have to tweak this or that. So again, big picture, doing integrated behavioral health, recommend, number one, using the collaborative care model for two reasons. Number one, it has the best evidence that it works. Number two, it's reimbursable. Next, two ways of doing video-based telehealth. One is by providing consultation between a psychiatric consultant and the primary care clinic. And then if needed, and that patient needs a higher level of care, or you need the psychiatrist or psychiatric NP to lay eyes on that patient, you can also do that over video. And just as a small example, we are using precisely this model in our practice is working with Rosebud Health Center in Forsyth, Montana, and we're doing this very model. We're providing consultation services to the team there, and then when and if needed to see them at a higher level of care, we can do a consultation, see them face to face, and either confirm or tweak the diagnosis and the treatment plan. But again, that's something that you know, whatever psychiatrist you might have in your community, hopefully they'd be in a position to do that for you, and again, really serve as a support and allowing patients to stay in their community and to stay in the clinic where they feel most comfortable. And with that, I will open it up to questions, and I will stop my little sharing gig here. All righty. Oh, Rebecca, you're on. Oh, good. So Rebecca, so I just saw Rebecca's comment. So yes, I'm working with Rebecca on this, saying this model really does work. We have a patient who started out with a PHQ-9 score of 21, is now down to a 9. Oh, that's awesome. Yeah. So again, we've worked together, and thankfully it worked out really well in this case. So thank you for that comment. Other questions?
I had a quick question for you on the registry that you were talking about. So is there some special type of permission that they have to get from the patient to participate in that registry? Or is that kind of in the care agreement?
No, it's a great question, because what's happening is you're enrolling the patient in this program, right? So it's the collaborative care program. And what happens is the patient, you know, I think out of full disclosure to the patient, I think telling them kind of what program, you're enrolling in this program that has a robust evidence base that really works. So I think it's critical for psychoeducation and saying, hey, look, what's going on with you is something that we can address here in primary care clinic, and we have a team-based approach. And so what you're doing is, first, you're helping them understand what's going on with them and helping interpret, let's say, the PHQ-9 score, right? So PHQ-9 is the depression screening score. And so, for example, in this case, the one that Rebecca pointed out, a score of 21 is really severe depression. And so what we're going to do is monitor that every time we talk. And as we do that, I, as the behavioral health care manager, will be having conversations with a psychiatrist on a regular basis to make sure that our treatment plan makes sense and it's aligned with your goals, and that you're getting the care that you deserve. And so again, what you're doing is really you're asking for consent. You're providing sort of disclosures. And the other piece is, depending on insurance, there may or may not be a copay. So they're going to want to know what they're paying for. So I think those are kind of the different reasons you may want to kind of have that conversation with the patient and let them know what they're doing. But I think the other thing is, if you're doing the collaborative care model, you're also hopefully giving the patient hope that what you're doing has a very strong evidence base, and that it works, and that can help them. So I think that's the other. So I think other important reason to do that.
Okay, good deal. So how would somebody get started with integrated behavioral health? If they're just kind of starting to fill it out, they pick a model, they go with this model, how do they need to contract with somebody, or what are kind of the steps there?
So I would call Rebecca, because I like the way that she do it. She'd do it. Geez, my English is improving over time here. So the way that Rebecca did it is she just started. She's like, Eric, I'm gonna start looking at PHQ-9 scores. We have, and like Amber suggested here, some clinics are just tracking PHQ-9s on a spreadsheet. That's fine. A registry doesn't have to be anything fancy, and you can start collaborative care tomorrow. Actually, don't wait. Do it today. So it's super, super easy. You have a spreadsheet with PHQ-9 scores and patient names and the last time you saw them. So, and then sort them based on highest score down to lowest score, and then pick the top 5 and say, you know what, we're going to start with these. So pick the top 5, and then pick somebody on your team who is going to be the behavioral health care manager. And what you don't need an LSCSW, you don't need an LCPC. You need somebody who is either a certified and registered nurse, as somebody who has certification in healthcare, okay, and is willing and listens well, cares about patients, and has empathy. That's step 1, because I also understand a lot of communities can't go and hire an LCSW or an LCPC. You don't need to. In fact, a lot of the research that was done at the University of Washington that showed they were doing better than treatment as usual didn't use counselors. Their behavioral health care manager was a nurse who cared about patients, who was willing to listen to patients, and was willing to pick up some tools. Because really, the intervention oftentimes is, let's say, as you're keeping track of the patients, sometimes the intervention is just reaching out to the patient and saying, how are you doing today? And the collaborative care model, when you get reimbursed, gives you the funding to be able to do that. So you get paid for the first month, you get paid for 70 minutes of intervention, which includes talking to the psychiatrist, calling the patient, managing the registry. And so you're getting reimbursed to play offense. And that's the way I would think about the collaborative care model, right? Because too often in medicine, we're getting paid to play defense, wait for patients to decompensate, and then you got to scramble. This is different. This is giving you the opportunity to track scores, stay ahead of these scores, and when you're seeing somebody, let's say, struggle, you reach out to them. And the power of just reaching out and letting them know that you're monitoring their progress can be very powerful and very therapeutic. And so again, I believe strongly that any clinic can start this tomorrow. You don't need anything special, except, again, now, back to your question, your question or your comment there, Mary, is yes, if you have a local or a psychiatric provider that is willing to give you an hour a week to discuss these cases, that's what you need. So imagine you have a behavioral health care manager who can manage up to, let's say, 30 to 50 patients in this patient registry it's a spreadsheet, and all you need is 1 hour psychiatrist time to take care of these 30 to 50 patients. And basically, so what you're doing is you're leveraging your limited resources and are able to provide care to more people than before.
Absolutely, that's awesome. So let me go back to, I don't think we have any questions in the chat just yet, but
okay.
Could you elaborate a little bit more on how it works for the patient themselves? So I'm
Sure.
hearing, regular routine interaction, that kind of thing.
Yep. So imagine you have this you have this registry, but which is really a spreadsheet. And I think about it as a dashboard that allows the behavioral health care manager to again, monitor this panel of patients and track their progress. For the patient, as if many of these clinics are screening people anyway, so nothing really changes, except that now what does shift is, well, 2 things shift, because things shift for the patient and things shift for the primary care provider. The way I would pitch it to primary care providers, saying, look, we know you're busy, you have a limited amount of time, we're going to start this collaborative care model, which is going to take some things off of your plate and make things easier, but we're also going to be able to, as a result, provide a more robust mental health experience for our patients. So Patient comes in, does a PHQ-9. PHQ-9, let's say, is 19 points, would be moderately severe depression. And the medical provider says, wow, I just noticed, you scored a 19, that's moderately severe. We're glad you filled this out. I'd like to have you, let's say Mary is the behavioral health care manager. After we finish our interaction here, I'm going to walk you down to see Mary. And so patient finishes, and then you do a warm handoff to Mary. And at that point, Mary would have the conversation, say, hey, look, here's what we have to offer. We have to offer this integrated behavioral health. Here's what the team looks like. Here's how we'll be tracking you. And depending on the plan you come up with the patient, for example, at a 19, at that point, you're probably going to want to have a conversation around risk, right? Any self-harm or suicidal thinking. And if not, great. If there is, then you follow whatever your standard protocol is for risk. But if there's no risk, but the patient is feeling very depressed, you may want to say to them, why don't you come in at the end of the week and let's touch base again? Or you make an appointment 2 weeks from now, but then you call them in a few days because now you're managing this group of patients, and you can use all the tools at your disposal and get reimbursed for it. And so, and think about the difference, right? Because in another situation, it might have been where the primary care provider says, wow, PHQ-9 score of 19. Tell you what, here's a card for the local mental health center. You should give them a call. And so, the likelihood of something actually happening goes down by a lot. They get lost to follow-up. And if they do make an appointment, sometimes it can take a long time to get in. Or if it doesn't take a long time to get in, it's not always easy to get information back from the mental health center to kind of be able to really care for the whole person. And so what you're able to do is keep the patient within your clinic, provide them the care that they need and deserve, and it happens quickly, and it happens with the same team that they already trust. So it does a lot of, really provides a lot of benefits. Question here from Amber: how many of you have started your IBH program or are thinking about starting? And yeah, so feel free. Yeah, what roadblocks are there? I guess that's if for those of you who are on, what roadblocks are out there that maybe you're thinking, okay, this guy thinks it's so easy. He hasn't thought of these things. I mean, throw it out there. I'd love to hear about it and maybe think through it with you. Or if there are no roadblocks, clearly there are going to be 45 people starting IBH tomorrow. So that's good.
I think so. I think that's just how awesome they are. So what kind of roadblocks do you usually see?
So I think honestly, part of it is, I think part of it is just inertia and feeling overwhelmed because this is so complicated, and it's not. I think all you need is you got PHQ-9s, you have a spreadsheet, and you have somebody who's willing. Again, it could be a nurse who's willing to be the behavioral health care manager. Now, there are going to be some questions. Well, gosh, who does the therapy? The nurse isn't trained to do therapy. Well, it turns out there are some inexpensive or even free training programs for some very basic psychotherapy interventions. So the most commonly used psychotherapy interventions in the collaborative care model are, there's CBT, there's motivational interviewing, there's something called problem-solving therapy, and there's behavioral activation. You don't need a psychoanalytically trained psychotherapist or with a PhD or an LCSW to do this. The magic in therapy is caring and empathy. You don't need a PhD to help people. And I think you guys, and I think we all know that, right? 90% of it is listening and validating and showing empathy and care. And especially in mental health, that's powerful. And so if you can combine that with, again, so you have some basic tools for very basic psychotherapy. And again, you don't need to be the one diagnosing. That's your primary care doc can help you with that. And your weekly consultation with a psychiatrist can help you with that piece. All you need to do is care passionately about this work and just be willing to play offense. And again, you have people to fall back on. Rebecca made a comment here. Our biggest challenge was just putting boots on the ground. The hesitation was due to not feeling prepared. And I totally get that. And especially primary care teams are probably never going to feel 100% prepared. I think part of it is just, what Rebecca and I did is we just talked very closely about, okay, step one, and we just kind of walked through the steps together, because I'm also learning because every clinic is a little bit different. So I'm going to learn the process and the workflow of each clinic. It's going to be just a little bit different. And every clinic is going to have different strengths and challenges, the same way every psychiatrist is going to have strengths and challenges, like anything, right? So question is, do you have some suggestions for mitigation strategies for staff turnover and care, care coordination in IBH? So I guess what I'm understanding from that question is, I guess really when staff turnover happens, how do you manage that? Well, so a couple thoughts. I think part of it is because this is a challenge that when I was chair of the psychiatry department at Billings Clinic, same kind of challenge, right? So I've been in an interesting way. I've been part of sort of administration as well as sort of, on the front lines. And so I think what's potentially powerful with collaborative care is it forces you, because you have this registry, it forces you to collect data. And since you're forced to collect data, you get to track progress. And when you track progress, you get to see your wins, right? And so kind of going back to the comment that Rebecca made around PHQ-9 scores dropping from 21 to 9, that helps morale, right? That helps you understand that actually you're making a difference. And so you get to actually track week to week these PHQ-9 scores and kind of notch up your wins. And so what I'm hoping is doing something like that will help reduce staff turnover and improve morale and people, because in healthcare, especially these days, morale is it's tough. And so I guess what I'm saying is perhaps using this as a way to provide feedback to the teams, showing them how, what gains they're making, and also having periodic meetings perhaps with a psychiatric consultant as learning opportunities, right? Because people love to learn and love to learn new things. And so this is learning a whole new intervention that has some very robust evidence that it works. So anyway, so if Alona, Alana, if you have more questions, if I didn't answer your question, please throw out another question. Looks like in the Q&A box there was, we're contracted with an MFT.
Yeah, there's
oh, sorry.
From Karen. Mm-hmm. They're contracted who reports directly to the providers, but not a behavioral health care manager. So I'm not sure.
Huh.
They've had very few referrals and it has worked, but is having a behavioral health care manager a requirement is their question.
So say that again. I apologize. So I'm not seeing all.
So they're contracted with an MSP who reports directly back, but not a behavioral care manager. And she's wondering if the behavioral health care manager is a requirement of IBH.
Got it. Okay. So far we had very few referrals and it has worked. So I guess I wonder, and MFT, I guess, is a marriage and family therapist. That's what I'm guessing. Is that what that stands for, MFT? Marriage and family therapist?
Yeah.
Karen?
Yep,
yes. Okay. Thank you. Okay. So interesting. Reports directly back to our providers, but not behavioral. So here's how I would try to shuffle that. I would kind of try to reshuffle that. I think, so the MFT, so again, stop me if I'm going down the wrong path here, Karen, but the MFT can be the behavioral health care manager, right? So the MFT can be sort of that quarterback, let's call it. And, in terms of, there really shouldn't be sort of a reporting structure, even though I know there are always hierarchies, but, the MFT or that behavioral health person should be kind of like the quarterback. And so you could have that person do both, right? Because you can do this two ways. One is you could have a behavioral health care manager that manages the database, the registry, and calls the patients, and you can have somebody else who just does the therapy. Most cases in rural settings, you're going to have only one person who's going to be able to do those things. So the MFT could do both, right? So the MFT could be the one receiving the warm handoffs from the providers and then sitting down, explaining the collaborative care model, and then putting that person in the registry and does the tracking and the brief psychotherapy interventions. But that person also can do this consultations with a psychiatrist or the nurse practitioner, and speaking on a regular basis on a weekly basis to the psychiatrist or psychiatric consultant. My guess is, Karen, I don't know what clinic you work in and what the volume is, but But I mean, if you think, and if you're trying to think about how to estimate or guesstimate volume, here's some thoughts. Number one, in the population, 20% of the population will meet criteria for mental health problem today. So you may imagine sort of 20% of your clinic will probably meet criteria if you give them all the PHQ-9. They might, and again, keeping in mind PHQ-9 is for depression, but it's a pretty good proxy for overall kind of distress anyway, right? Because even somebody with an anxiety disorder is probably going to score high on the PHQ-9 because they're going to want to tell you they're struggling, right? So anyway, using the PHQ-9, provides a lot of information, obviously. So again, 20% of the population will meet criteria for a mental health disorder. The PHQ-9 should probably capture a lot of that. And sorry, just looking at the latest sort of update here. But what I would imagine is if the providers know that you have a smooth path after the PHQ-9 score, I wonder if they could be more willing to use it then and maybe have more referrals. Because I'm wondering if the providers maybe haven't been educated, or they've been educated and don't want to understand, or maybe they don't understand. They need kind of re-education on why this is a good model, why it makes sense, and you don't have to handle this all by yourself. We can provide help, because you might have some providers who are stubborn and be like, no, I got this. Well, that's not fair then, because then you're not referring to something that has a very, very strong evidence base that actually helps patients. So it might take some marketing to the providers too. Karen, we are private internal medicine PCP office. Most of our patients score low on depression. Oh, well then, that's good. Now I wonder, do they score low because they want to score low, or and they don't like to flag that they're struggling? Because you also, if you may not want to always just rely on the numbers. In fact, I've certainly seen, I'm sure we've all seen this, where a patient kind of scores low on a PHQ-9 or another screener, but is really struggling. Like I was talking to somebody about this. I can't remember. I was talking to somebody about this where they said, scored out low on a PHQ-9 score, but they were bawling as they were handing over the paper. So obviously that warrants a referral and further screening. So again, so perhaps, Karen, you either don't have a problem with patients who are struggling with anxiety and depression, so that's great, or they are underreporting, or the internal medicine folks, the providers maybe don't quite understand all the benefits of this model. I'm not quite sure, but I'm also happy to speak offline about that as well.
Yeah, definitely, Karen. If you'd like some more help, feel free to reach out to Dr. Arzubi or myself, and we'll get you connected. Good deal. So great. Thanks for the questions and the interactions. Seems like that half an hour just kind of blows by. The next session we're doing is next week, using telemedicine to manage depression. So it'll be same format, kind of a quick Q&A that we're doing. You shouldn't have to register for the event, but you may need to add it to your calendar. Sometimes the series doesn't add to your calendar, so logistically you may need to add that information to your calendar. So thank you so much for your time today, Dr. Arzubi, and everybody else on the call for participating. Let us know if you have any other questions or follow-up, or need some follow-up information from us. We will be putting these materials that Dr. Arzubi shared today out on our telehealth website that I showed you briefly as part of the presentation. So thank you all. The recording and everything will make its way to you in a day or two once we've edited and made sure that it's all cleaned up.